My name is Akil Patterson, Chair of the Drug Price Affordability Commission. Today is November 15th, 2023. I'd like to call this meeting to order. Melissa, can we please call roll?
Chair Akil Patterson.
Present.
Vice Chair Shelley Bailey.
Present.
Dr. Richard Bruno.
Present.
Dr. Amy Burns.
Here.
Dr. Daniel Hartung.
Present.
Robert Judge and John Murray are excused, and we have a quorum, Chair Patterson.
Thank you very much. At the October 18th meeting, Vice Chair Bailey, thank you very much for overseeing that meeting. At this time, I need the board to approve the minutes for today. So are there any changes to the minutes from October 18th of 2023? Being none, is there a motion from the board and a second to approve the minutes?
Move to approve.
And I'd like to second them.
Move to approve by Dr. Bruno, seconded by Vice Chair Bailey. Melissa, call the roll.
Daniel Hartung.
Approve.
Amy Burns.
Approve.
Richard Bruno.
Yay.
Shelley Bailey.
Aye.
Akil Patterson.
Aye.
Motion passes.
All right. And with that, we have gotten through normal business to start the meeting. Ralph, our Executive Director, if you can provide us with an update, please.
Thank you, Chair Patterson. Good morning, everyone. I will be brief as we've got a lot to cover today. DCBS did hold a Rules Advisory Committee on Monday for implementation of provisions of Senate Bill 192 to expand carrier reporting for the Drug Price Transparency Program and new reporting requirements for pharmacy benefit managers for the first time. Also relating to Senate Bill 192, I can share that our RFP did post on November 1st. It will close on December 1st. As a reminder to folks, that's for a contractor or vendor to help facilitate meetings with carriers, hospitals, pharmacies, consumers, and state drug purchasing programs to develop an implementation and operational plan for upper payment limits. I do anticipate being able to announce a successful bidder at the January meeting and present a work plan for stakeholder engagement. I will also note that we did receive one application from a rural clinician to fill the vacancy created by Dr. Spain's resignation in September. That name has been forwarded to the governor's office for consideration, and we hope that that individual will be joining us in February. I will also take this opportunity to promote and share that the PDAB sibling program, our drug price transparency program housed at DCBS, will hold its annual public hearing this year on Thursday, December 7th from 1:30 to 4 p.m. This year's hearing will be virtual. Attendance is by Zoom. No registration is required. You'll be able to hear presentations and highlights on policy recommendations from the 2023 Drug Price Transparency Annual Report and an agency presentation of findings from that data and reporting. There will be several panel discussions, one on diabetic drugs approved to treat weight loss, and invited presenters will speak about expensive drugs used to treat diabetes that are also now also approved for chronic weight management in non-diabetic adults with obesity. The second panel will be on generic drugs. What determines the cost of generics and why are so many so expensive? Invited presenters will speak about why some generics are so expensive and have a very small discount when compared to brand name drugs. The hearing itself will be facilitated by our insurance commissioner, Andrew Stolfi, and the panels themselves will be moderated by Oregon legislators who will ask questions and lead discussions about panel presentations. There will also be 2 sections for public comment. We take this opportunity to encourage consumers to sign up for that opportunity. They can do so at rx.prices@dcbs.oregon.gov or simply go to the drug price transparency website for more information on that. Also encouraging consumers to share their stories about how prescription drug prices have affected their lives and report cost increases to the program. Chair Patterson, in the interest of time, that is my brief update. If okay with you, I would like to go ahead and introduce our presenter for this morning.
Please continue in introducing the presenters from Harvard.
Thank you. I'm pleased to introduce Dr. Yan Emily Yuan. Dr. Emily is an endocrinology fellow at Brigham and Women's Hospital. She received her undergraduate degree from Harvard College and graduated from the University of Massachusetts Medical School. She completed her internal medicine residency at Brigham and Women's Hospital, where she was part of the clinical and transitional research pathway. She'll be joining the cardiovascular endocrine research group to study the genetic susceptibilities of salt-sensitive hypertension. She has a Master's of Science in Narrative Medicine from Columbia University, where she studied how the skills of reading and writing of literary text can help inform the clinical encounter. In addition to her clinical research and interest, she is passionate about medical evaluation. In 2020, she was awarded a Fellowship Teaching Award from the Brigham and Women's Hospital and Harvard Medical School. We welcome Dr. Yan, and she will be joined, I believe, by Dr. Ben Rome, who has previously spoken with the board. So again, gratitude and welcome, Emily.
Yeah, thank you so much for that kind introduction. I just want to clarify for logistics, you will be advancing my slides, is that right?
Yes, that's
Yes.
correct.
Okay,
Yes,
great.
I will.
All right. All right, well, good morning and thank you so much. So the purpose of this talk is to provide an overview of insulin therapy with an emphasis on the different types of insulins that are available. Next slide, please. I have no disclosures. Next slide. So here is an outline for the talk. To start, I want to provide a brief primer on insulin and what it means to achieve glycemic control. I will review the broad clinical categories in which insulin therapy is necessary. Then we will review the different types of insulins. I will show a summary of the insulin delivery systems. And then lastly, we will delve into the clinical approaches to insulin therapy. And here I will include a comparison of specific insulin formulations that are available on market. Next slide. So briefly, insulin is a hormone that's produced by the beta cells of the pancreas. It functionally allows our body to use what we eat. So the pancreas secretes insulin in response to glucose and other hormones. Insulin then allows our muscle, fat, and liver to take up and use glucose for energy. It allows glucose to then be stored in the liver and turn off further glucose production, thereby helping to maintain a certain glucose level in our body. It also prevents the breakdown of muscle and fat for fuel. And now this is really important because without insulin and the ability to use glucose, the body will default to breaking down muscle and fat, which will lead to the generation of an acidic compound called ketones. This can then result in a life-threatening complication called diabetes ketoacidosis, or DKA. So before the discovery of insulin in 1921, diabetes mellitus was considered a fatal illness. And shown here on the right is a young patient who has insulin deficient diabetes before and after treatment with insulin therapy. In the discussion about insulin and the cost of insulin, a quote that is frequently cited is by Dr. Frederick Banting, who was one of the researchers who discovered insulin and subsequently sold the patents to the University of Toronto for $1. And he said, "Insulin does not belong to me, it belongs to the world." Next slide, please. So with that, let's just review what it means to maintain glycemic control. In healthy individuals, there's a level of glucose that the body always tries to maintain. This is the baseline or fasting glucose. Now, when you eat, there's a glucose spike, and shown here is an example of an individual who is eating roughly 3 discrete meals around the time of 8 a.m., 12 p.m., and 7 p.m. In order for the glucose levels to return to baseline after the meal, we need insulin to help the body take up the glucose and use it for energy. Next slide. So now let's just look at what happens in clinical situations where there is insulin resistance. And common examples are uncontrolled type 2 diabetes mellitus, gestational diabetes mellitus, and steroid-induced diabetes mellitus. And here what we see is that the baseline glucose level is already elevated, and with each meal, the glucose surges above that baseline, now to critically high levels. The body itself is less sensitive to the amount of endogenous insulin that is being produced by the pancreas, leading to an imbalance where the glucose levels are constantly higher than the healthy targets. Next slide. In insulin deficiency, and the most common example is the autoimmune disorder type 1 diabetes mellitus, there is a destruction of the beta cells in the pancreas that produce insulin. And so as a result, we see a similar glycemic trend of higher baseline glucose and glucose surges with food intake. The problem here is that there is insufficient insulin production, but the body is sensitive to insulin. So therefore, the amount of insulin relative to body weight that is needed to treat individuals with type 1 diabetes mellitus is often less than what is required to treat individuals who have insulin-resistant diabetes. Next slide. And then if you can just click once. Oh, do you have the PowerPoint presentation or no?
Yeah, yes, I do. Let me switch to that.
Okay.
Would you like me to switch to that?
Yes, please.
Okay. Which page were we on, Emily?
If you could, so this looks like this is still the PDF version.
Oh, yes, it is. I'm sorry. Let me get back to we do have the PowerPoint, but we added it to our own PowerPoint. So, okay, let's try this.
Great. If you keep clicking, I'll tell you when. Okay. Can you go back?
Yes.
And then if you click once. Okay, I don't think this is the PowerPoint version, but that's okay. I think in the interest of time, we'll just keep going. Yeah, that's all right. So this is a schematic. It's a very simple schematic of our goal when we prescribe insulin therapy. So, which is we want to bring both the baseline glucose and the mealtime glucose levels back down to the physiological targets. Next slide. So in order to do that, we operationalize different types of insulin that are classified according to their varying times of onset and durations of action. And we will get into this in more detail in the slides to come. Next slide. So before moving to the approaches to treatment, I just wanted to show one slide about the modes of insulin delivery. So most patients with diabetes will be familiar with using a vial and a syringe or a pen. Pens have the advantage of being more convenient. The injection is reported to be less painful, and therefore it is often associated with better treatment adherence, but it is more expensive. An insulin pump is a wearable device that uses either rapid acting or regular insulin. It offers the advantage of no injections and greater flexibility for insulin dosing. However, it does require a significant amount of user training up front and the acceptance of always needing to be connected to a device. This option is best for individuals where long-term insulin delivery is anticipated. And so, for example, in my patients who have type 1 diabetes mellitus. And then just to make a quick mention, there is one type of inhaled insulin that is available. And in our clinical practice, I see it used much less frequently than the vial and syringe or the pens and pumps because of limited dosing options as well as supply. Next slide. So let's now move on to approaches to treatment. For today, we will review two common approaches. The first is basal bolus, which requires somewhere around 4 injections per day. The second is pre-mixed insulin, which requires around 2 injections per day. Next slide. So let's just first remind ourselves of what we're contending with, which is we have both elevated baseline and mealtime glucose levels. And in order to address this, we divide the problem and say, okay, first, I'm going to give one type of insulin that's going to target the elevated baseline or fasting glucose. And so I'm going to need an insulin that has a very long duration of action and a relatively slow onset of action because I don't to cause any low blood glucose. And so this is what is called the basal insulin. And I can do this in a couple of ways. One is by administering a long-acting insulin that lasts about 24 hours a day and can be administered once per day. Next slide. Next slide. Another way to do this is, back one. So another way to do this is to use insulin that lasts approximately half a day and administer it twice per day. And these are my intermediate acting insulins. Next slide, please. So before we move on to address the mealtime insulin needs, I just want to show a slide comparing the different types of long-acting and intermediate insulins that are available on the market. So these are summary tables, and you can see the manufacturer is listed in the first column, followed by the generic and brand names. Then we have the onset and durations of action, which are key pieces of clinical information. And then lastly, I listed the available formulations for insulin delivery. And you can see that most insulins are available in pen form. The highlighted insulins are those that were a part of the recently announced price cuts by the different manufacturing companies. Of note, however, just last week, Novo Nordisk did announce plans to discontinue Levemir at the end of this year. In the pen section, I've also included an asterisk next to the ones that are available at Walmart at a reduced cost under the name Rely On. So in clinical practice, the reality is that our prescribing of which type of insulin is really often guided by which is covered by a patient's insurance plan. And it's challenging also to make kind of population level conclusions of which insulin is quote unquote better based on the published studies, doing head-to-head comparisons of different basal insulins, because oftentimes these study populations are very targeted. So for example, they may be looking at just patients with type 1 diabetes with a hemoglobin A1C of less than 8.5%, for example. But I will highlight a couple of key differences. So the insulin degludec, for example, you'll notice that it has a much longer duration of action. It's also one of the newer basal insulins. And I have switched patients to this insulin in the past if I have seen that glargine was not providing them with a full 24 hours of basal coverage. Another note that I will make on this slide is that some insulin names you will see will have a U followed by the number 200, 300, or 500. These are what are called concentrated insulin. So that means you can give more insulin per ml of volume. And this option is really important for some of my patients who require very high insulin doses. So concentrated insulin allows for the reduction of dosage error and injection volume. And just to note, these are only available as pens. Next slide, please. So now that we've covered basal insulin, we still need to take care of our mealtime needs. So to address the glucose surge that comes from a food bolus, so to speak, we need to use insulin that is fast acting, but we want the duration to be fairly limited so that when the glucose is used up, there isn't still a high level of insulin, which would cause low blood glucose. Next slide. So here we have many options, and I've organized them in a summary table in the same way as the other slides. And so I will just say for bolus type insulins, I find the greatest value in options with the shortest onset of action. And so this means that patients can take insulin closer to when they are going to start eating rather than waiting 20 or so minutes after they've given themselves the injection, which is what we sometimes do need to advise. Next slide. So now that we've reviewed the basal bolus approach, I want to take a look at a different approach of achieving glycemic control, and that's to use pre-mixed insulins. Next slide. So just first, what is pre-mixed insulin? It's a formulation of insulin that combines a quote-unquote bolus type of insulin, that is rapid or short-acting insulin, with basal insulin. In this case, we're going to use intermediate insulin. And the available formulations are given names with two numbers that represent the relative percentages of a basal type insulin and a bolus type insulin. So for example, if you see 70-30, that's 70% MPH and 30% regular insulin. Next slide. So how did they work? Well, we have the same glycemic profile of an elevated fasting and mealtime glucose levels. And now instead of giving separate insulins that are going to be targeting the basal and mealtime glucose, you're going to give an injection with the intention of doing both at the same time. Next slide. So the advantages to this method is fewer injections, and this is really good for anybody who has trouble with self-injections or needle phobia. And I would say this method is suited for individuals who have a pretty set meal schedule and meal content, as well as activity level. And that's because the disadvantage of this approach is that it's much less precise for how we are approaching glycemic control, and higher risk of insulin to carbohydrate mismatch, which can lead to a lot of clinical complications. And sort of just, as a punchline, it's just much harder to titrate to my patient's needs because I'm making a couple of assumptions each time I'm assumptions about their mealtime and basal needs each time I make a dose titration. And so in my endocrine practice, we don't reach for pre-mixed insulin as a first line. Next slide. So similarly, I've included a summary table of the available drug options. Again, I pay close attention to the onset and duration of action when thinking about which to prescribe. And then last slide. So with that, I will end with the summary slide. I won't read this to you, and instead I'll just take a pause and see if there are any questions for myself or other members of the portal team.
Thanks, Emily. I know if there are questions for Emily, I think she has to hop off right at 1 for another meeting. So if folks from the board have questions for Emily, now is great. And then I'll be around for additional questions and to have more of a conversation about sort of implications for the board after.
Thank you, Emily. Are there any questions from the board at this time? Can't see all the hands, so if there is, please speak up, but I don't believe there are. Oh, Daniel, go ahead.
Just a quick question about, you mentioned one product that was exclusively available at Walmart, Walmart. Could you describe what that is again?
Yeah, it's not one product that's exclusively available at Walmart. It's a series of pens where Walmart is actually producing also having their own line. If you go back to the tables, I don't know, Melissa, if you could put it back on. So essentially the name of the pens are going to have the word relying on in the name. And these are pens that are going to be exclusively available at Walmart, and they're going to be relatively less costly than the other pens. And if you can keep flipping, so maybe the next, another slide forward. And again. And then if you can see in the table, so for example, in that second to last line, Novo Nordisk, and they make a regular insulin called Novolin, and this can come in something called Novolin R Flux Pen, and then there's a Novolin R Relion Flux Pen. That latter pen is only available at Walmart.
Yeah, and I think these are the same products as
Correct.
as the other Novo products. So the same company making the same product. It's just branded specifically for Walmart for a direct-to-consumer price, if that makes sense. And so it's only NPH insulin, which is like a 2 times a day intermediate acting insulin, and regular insulin, which is a short acting but not a regular, sort of a short acting but not a rapid acting insulin. I don't think any of the rapid acting options are available, or if that's right.
Yeah, that's right.
Okay, thank you.
And board members, any additional questions of Emily? It's a unique opportunity to have someone of this level of expertise to pick her brain. So please don't be bashful if you do.
So Emily, Chair Patterson here. Thank you again. Thank you very much for doing this. I was interested. So when you went to that first slide where you explained the basal bolus, it said up to 4 injections a day, but they're supposed to be longer lasting. I didn't understand, but it's up to 4 a day, but it's supposed to be longer lasting. Are the other ones short acting and you have to take them more? But it said 2 to 3 times a day. I'm a little confused.
Yeah, sure. So if you wouldn't mind going back one more slide. So when I say up to 4 plus or minus 1 injection a day, you have to take an injection to cover your basal insulin needs. So that's going to be either 1 or 2.
Okay.
And then if you can advance the slides. Again. And then you're going to need to take additional insulin to cover your mealtime needs. So that's going to be 3, or if you're going to eat more times than that, 4 even. And so injections to accomplish separate goals. And that's why the way that I kind of described it is insulin that's going to be used to treat your basal glucose level, and then these surges with mealtime. So it does come out to be about 4 injections plus or minus.
Okay. All right. So they're achieving different goals, but they're still longer acting.
Only the basal insulin is long acting because you need that to cover your needs for the whole day. And then the short acting or the bolus insulin, these are going to be the ones that are just going to be for your meals.
Just two different types of insulin, so patients get prescribed two different types of insulin for this approach.
And what's the general cost in terms of having? So the basal one is probably just one set amount. You get it twice a day, but then the bolus, how does that vary price wise for the consumer when they say they have 5 meals a day or something along those lines?
Yeah. Ben, I might have you tag in if that's okay, just for the interest of time.
Sure, no, of course, and
Okay,
thank you,
Thank you,
Emily, Dr. Mann, for a great presentation. To your question, Chair Patterson, I think when you say cost, I think there's 2 different costs. So one is how much insulin does a patient need, and that's hugely variable by patient, right? So there isn't one cost of insulin, of like how much it costs to purchase that amount of insulin, because some patients need 10 units of insulin a day, and some patients need 100 units of insulin a day or more. And so obviously, the actual cost of purchasing that amount of insulin is going to vary depending on how much they use. Patients usually get this in the form of pens. So you can calculate out sort of approximately how many pens you think they're going to need over the next 30 days or 90 days, and you prescribe that much. And then patient out-of-pocket costs are usually based on a 30 or 90-day supply, which depends on how the prescription is written. But as you point out, like people's needs of insulin can change over time, so that can be challenging. And I think doctors adjust the prescriptions over time to try to get it so that it sort of somewhat lines up with what they're using. But personally, I'm a primary care doctor, not an endocrinologist. So, but I always write sort of or as directed by doctor in my prescriptions for insulin, because what it says on the scripts can change after it's written.
Well, thank you very much. Appreciate that. If there are no other questions from the board, thank you very much. We appreciate that. I think now I want to call back on Ralph to begin discussions on our OR 925-200-100-110 board discussion and votes. This is for the insulin drugs and a vote on the subsets along with the orphan designation of prescription drugs and vote on updated subset.
Thank you, Chair Patterson. I will go ahead and introduce Amanda Claycomb, our research analyst, and Courtney Whitlock, our policy analyst, to lead this conversation. Dr. Rome, if you can stay with us as well for however long possible, if questions should come up from board as we do this, and remind folks this exercise around insulin, statutorily we are required to produce or identify at least one insulin product. The criteria for this is a little uniquely different than those identified in statute as it relates to prescription drugs. This is as it relates to highest insurer reports related to overall spend, per patient spend, and patient out-of-pocket cost. With that teed up, if I can introduce Amanda and Courtney.
Yeah, let's start off with Amanda talking about, but I think what Emily was just talking about regarding the variations of insulin type is going to be very beneficial for this conversation to select the, or to at least looking at the drugs and how to identify the subset. Amanda will be driving majority of the data presentation with the PowerPoint. So Amanda, if you can kind of take that and show it on the screen so we can start talking through. Thank you. So again, this is our working document for the insulin. I want to give Portal a really big gratitude and thank you for all the information and advice that they provided for us over the last few weeks. And so Ben, please feel free to jump in as we kind of start this conversation about how to look at these insulin via either the insulin type or kind of the drug base. One of the things that we talked about last month for the top drug list was to remove drugs that are on the CMS list. And we would like the board to consider that same kind of jurisdiction, since CMS or the IRA has already indicated that the drugs themselves have been in some capacity unaffordable. And so it's already being reviewed at the federal level. So it's suggested that the board consider removing those as we continue the discussion, and then we will look at other columns for this. So I just wanted to start off there, if this is maybe the first kind of drill down, or if the board wants to start a conversation about looking at the drugs that are either on or not on the CMS list.
I mean, I can say it does make sense to me that we don't necessarily need to duplicate efforts. And if the feds have already identified those medications, it does seem to make sense to me to remove them so that we can move forward with a more narrow list.
Are we talking about insulins only, or the whole drug list that we're considering?
So for this conversation, it's just around the insulins, because we need to kind of do what we did last month with the top drug list, where we're kind of drilling down to identify a subset for the insulin so that we can start reviewing them under the affordability rule under -020. So this is just for insulin.
Okay. I mean, I think that makes sense. I just will caveat that there's some time delay between when they will start or engage in negotiations and when that's implemented. So I think just being cognizant of that, things may change as we move forward. at
And
federal level.
One note on the on CMS, they chose, so the product that that is on that first list of 10 is actually two products. It's Novolog and Fiasp, which have the same base ingredient, but are branded as two separate products. So Novolog is older and Fiasp is newer. Fiasp is more rapid acting, so it's faster onset. And I think you can see in the data it's used far less frequently than Novolog, because I think it's more expensive in health and it's generally not covered as favorably. So both of those are sort of like bundled together and treated the same by CMS. From your perspective, you might want to think about them separately, but I don't have a strong preference either way of sort of whether to think about. I think excluding products that CMS is evaluating is fine, given that there will be a report coming out. Again, not immediately on those drugs.
Let's go with Amy Burns and then Richard Bruno.
Yeah, I just wanted to see if so you've got column A defiltered. Are these the Fiasp and the Novolog the only ones that are flagged as yes here?
That is correct.
Okay, that was all. Thanks.
Dr. Bruno.
Thanks, Chair Patterson. I just wanted to echo Dr. Hartong's concern about some of the potential delay on the federal side that we would have to consider as part of our discussion here. But I'm kind of torn. I would say, of it being sort of influenced by the list that's currently being considered on the federal level and our own process here.
Yeah, I think overall, I think we'd run into this in all the medications we will review, considering we are looking at data that is in the past, by at least by 2022, as we move into 2023 and now into 2024. So I think using the current data as best as we can aggregated would be the most beneficial way to at least come to pare down these and hopefully provide some recommendations to the legislator.
One other piece besides the CMS piece that was in Dr. Emily's slides was the fact that some of these products are changing in price as of next month or in January. And so that includes Novolog, Lantus, Humalog, was going to include Levemir, but now that product's just going to be discontinued. So, and for those cases, it poses you with a separate challenge, which is that the price that's going to be in effect in January will be different, and therefore sort of the out-of-pocket costs will sort of not be necessarily the same. Insulins are heavily rebated. There's a lot of competition, even between the three big insulin makers, and so PBMs have been aggressive at getting rebates for these products, and so the sort of net cost and the list cost is very different. And the thought is that these new lower prices will essentially get rid of those rebates or bring them down substantially. And so patient out-of-pocket costs could go down as well if patients are paying based on the new prices as opposed to based on the sort of old inflated prices. So another thought for you all in moving forward is to really consider products where that's not at play, given the timing of your review. It might make sense to review one of those products, but it might make sense to wait until we sort of see what happens with those new prices. So anyway, I'm happy to talk about which ones are not on that list if it would be helpful.
Okay. So with that, staff, can you read your recommendation one more time? Unless Dr. Bruin, did you have another question, or is that just an old hand? All right, staff, could you read the recommendation one more time for the board?
We don't have the recommendation. It's just based off of the conversations that we've already had with Portal in some degree, which is kind of looking at should the list remove products that CMS is going to be looking at, kind of as the first filtration process, since that kind of is the discussion you just had, or to continue to include it and see what the next step of filtration needs to be.
Yeah. Well, I believe we should filter. Is there any dissent from that? Or I know we've heard, saying that we should be mindful of it, but as we continue to pare down.
All right, assuming none, Amanda, why don't you continue with your presentation and discussion? I know ultimately, I think we're going to look for some commentary from Dr. Rome, possibly about some of the newer generation insulin products. So try to keep the conversation moving.
Yes, of course. So on screen, we have the detailed data broken down by the aggregated proprietary name. We also have a tab by the drug base. But we did want to recommend looking at the proprietary name level, as they can really vary from different forms of the drug that when you aggregate it together. I know one of the discussions that we've had with Portal is whether or not to consider the newness of an insulin. And Dr. Rome, I don't know if you want to speak a little more to that.
Yeah, I mean, I think that newness probably is reflected in part in price. I mean, I think of the products, again, there's a lot of products here, and I think the question for you all is how many you want the staff to review. One way to filter before you talk about newness is just how frequently some of these are used. Some of them are used very, very infrequently and might not, just ultimately, you could make an argument that they're used infrequently because of, because they're not covered well, or maybe the cost is prohibitive, but also it could just be sort of clinical use patterns. And so among the ones that are used commonly, if you think about sort of older versus newer generations, so typically the intermediate acting insulins and the regular insulin. So this is like regular insulin, insulin NPH are older, and those are the ones that tend to be the least expensive. Something Dr. Yuan mentioned is that these products are some of them are available at Walmart at a discount. So that's, so you can get the sense that like the companies are willing to sell those products lower price. The immediate acting insulins and the longer acting insulins, are the ones that are kind of the newer generation. But even within that, some of them have been around now for quite some time and are facing competition. So insulin glargine, insulin lispro, insulin aspart all have kind of competition starting, and that's in part why the companies are lowering the prices for these drugs next year. So I mean, I think there are, and then there's sort of even newer ones than that. So insulin degludec falls into that category where it's even newer. So I don't know, if you want to filter to and sort of show by FDA approval date, maybe if you just even sort Amanda instead of, that'd be easier. Some of these newer products, I will say some of these newer products are biosimilars. So Semglee, insulin glargine, that's a biosimilar version of Lantus. Whereas insulin degludec is a separate product. Same thing with Basaglar. Basaglar is essentially a follow-on product to insulin glargine. So Lantus, Basaglar, Semglee, and there's even a newer one that's not here because it's 2023, are all the same product, just with different kind of, you could almost think of them like generics of the same base product, even though biosimilars have a little bit of complexity. The other newer ones like Tresiba or insulin degludec, Tueho is a even longer acting, sort of more concentrated version of glargine. Levemir are sort of newer long-acting insulins. Levemir would be reasonable to consider, except again, the company's discontinuing sales in the US, so I would just highly recommend you not even consider it. That's news as of like last week.
Vice Chair Bailey is recognized.
Thank you, Chair Patterson. Just as we think of narrowing the list, and I see that Afrezza doesn't have very many claimants, like could we, one thing I guess I'd like to consider us looking at the data for would be the first FDA approval date, which we already have, but then maybe filtering or at least less prioritizing the ones that have had a decrease in per change patient spend, and then prioritizing like the number of claimants. I don't know if we can achieve all three of those things, but to try to see where we could make the most I guess impact the largest number of people, keeping in mind that some of these have really had a considerable change in patient out-of-pocket spend. That's just something to consider. So I guess like looking at the FDA approval dates, 2015 makes sense to me just because the Afrezza has low volume. I welcome other people's thoughts. I was just trying to look at a way to get us to narrow our list.
The one piece about per patient spend that you have to think about is that utilization can change over time as well, especially because insulin use is super variable, and so you just have to be a little thoughtful that it may not necessarily just reflect a change in price. It might reflect a change in utilization.
Okay, that makes sense.
Does that make sense? Because if if an individual patient uses 100 units versus 10 units of insulin a day, right? Like they're going to have different costs. And so suddenly if you switch towards like patients who use more and more insulin, that could lead to so you just have to be a little bit cautious of numbers in insulin, because there isn't a clean way to say sort of like what's the price per year per patient, if that makes sense.
Do you have an alternative suggestion, Dr. Rome, that if we remove that but try to get at the spend piece, would you overall spend instead?
Yeah, I mean, I think looking at the out-of-pocket spend per patient is reasonable, because again, that gives you a sense at least, you know, of which ones are on the high end and which ones are on the low end. And again, I mean, if you're looking for things to exclude, not based on sort of data, I would say excluding the things that like are covered by the IRA, where the price is changing or where the drug has already been sort of discontinued, seems very, very easy. And if you were to remove all of those products, you might have a much shorter list. And then you sort of like, your question is sort of how to prioritize within that. I would say like number of people using the drug could be a easy way to prioritize. It's pretty straightforward. You probably want to focus on drugs overall and prioritize drugs overall that are used by the most folks in your state, since that'll have the biggest, you know, the affordability challenge will be the biggest. Again, you could make the opposite argument that like drugs that aren't used maybe because they're too unaffordable, but it's a hard, you know, it's kind of a combination of that plus clinical use. So that's sort of my general thought would be sort of rule out the ones where there's like a pretty clear reason that like it just doesn't make sense to do a review, and then maybe prioritize in order of use. And I think if you do that, drugs like insulin degludec will end up towards the top of the list where it's the prices. And I think just if you look at the total users, right, there's like 12,000 users compared to like hundreds of users of some of these others. So it's orders of magnitudes more use.
Chair recognizes Amy, Dr. Burns.
Hey, yeah, I would agree with Dr. Rome. That was my thought as well. And I think we talked about this last month. Really going through the highest utilized agents makes the most sense. Like that's what's going to affect Oregonians the most. So the highest number of claims, the highest number of claimants, and then making decisions about if we have to further kind of pare down the list, that makes sense. So starting with what are people using?
Would it make sense to also remove the biosimilars?
Yes, it shouldn't. Oh, my apologies. Chair Patterson, we can remove those that have a therapeutic equivalent or biosimilar. With insulin, that really only impacts Lantus, Semglee.
Okay. Right, and I would say Basaglar is essentially, so there are two that are not formally biosimilars, and the reason for that is a regulatory change. So before 2020, insulin was categorized by the FDA as a small molecule, and after 2020, it was categorized as a biologic. The reason for that change was because the FDA was struggling to figure out how it would approve generic insulins. There was no clear way for the FDA to think about the insulin product being similar enough. So before that change, Basaglar and I think Admelog is the other one came out, and those two are essentially biosimilars of Lantus and Humalog, respectively, I believe. But they aren't formally listed as biosimilars by the FDA, right? They technically are a separate product, even though they have the same ingredient. After the 2020 change, then the only biosimilar that you'd have on your list, I believe, would be Semglee, which is a biosimilar of Lantus. So, Lantus effectively has two biosimilars on this list, Basaglar and Semglee. So if that's helpful. So, I mean, I agree. I wouldn't review biosimilars. The hope there, unless you have some strong reason to, there's some concern that biosimilars aren't priced, that much lower. But I think, again, all things considered, given your resource constraints, biosimilar competition, the hope is that it brings down prices. And so, you don't necessarily want to, I think it might be a little early to weigh in on that topic.
Yeah, I'm Ralph. Chair recognizes Ralph.
Yeah, thank you, Chair Patterson. Dr. Rome, I'm curious, given Emily's presentation and things that you said about, highly irregular, inconsistent patient usage is very patient specific. Therefore, question if you think that column S there is still a meaningful number with utility, and how we should be framing up those that we see a net cost decrease if you were to conceive year over year in aggregate people's needs, what would remain fairly constant amongst the masses of people that use insulin.
It's a hard question to answer, Ralph. I think this, and that's not out of pocket, right? S is total cost. Am I getting that right, Amanda?
S is actually, so what I took was, because you addressed one of the concerns that I had, which is previously we had shown a change in the overall spend, but you are absolutely correct. That is dependent on volume. And so from last month to this month, I added in a field to review the per patient spend between 2022 and 2021. And so that way it would factor in if more or fewer patients were taking the drug. So
right. So it does factor in more or fewer patients. It does not take into account if there's been a change in the number of units used per patient. That's the one piece that's, so but across insulin products, is there a good reason to believe that that's changing year over year? I don't know. I mean, Ralph, probably not a great reason.
And just to add real quick, if we do filter by those that have a percent change per patient spend between 2021 and 2022, that will reduce the list down to 26 insulins. And let me make sure I've got, when we filter out the therapeutic equivalents and those on the IRA list.
And the other piece is, Ralph, I don't, and Amanda, correct me if I'm wrong, that overall spend is pre-rebate spending.
Correct.
This is the claim level spending, right? So that's the other big challenge with using any sort of overall cost. That's why I prefer to look at out-of-pocket costs, because those can be affected by patient coupons, but they do reflect really what the patient is being charged at the point of sale, unless they were to seek out an alternative way of paying for the insulin. The overall costs are hugely rebated, and even from, again, we don't know specific rebates for specific drugs technically, but actually insulins have been studied fairly well by Congress, and the rebates are north of 75%. And we know that in part too, because the prices for the price reductions we're going to see as of January have been announced, and they're like 80% price reductions. And so that gives you a sense that, like, again, the actual spending per patient is far, far less than what this shows, and it might vary a bit by drug. So that's another reason to just be very, very cautious using like price or spending data to guide your decision making. I think out-of-pocket cost data might be reasonable to guide your decision making, but if that makes sense. I thought Amanda, I saw an out-of-pocket cost on a previous version of this, but maybe it's not.
Yes, it's, and my apologies, I'm using the original column name from the APAC export, but it's the expected patient paid as the out-of-pocket costs. Once again, APAC data does not include any sort of rebates, price concessions, coupons.
So the per patient, right? The patient paid amounts, I think, are the per patient, that 2022 patient per, where's 2022? per patient spend, but that's the out of pocket.
This is actually the overall divided by
I see.
the.
Right. So I would say taking the patient pay divided by the that to me is a more useful measure. Like which ones are patients paying a lot more for is more useful to me than total.
I can do some quick math on the screen, Ralph or Courtney, if you're comfortable with me adding in a column real quick to show that.
Yeah, fine doing so. Chair Patterson, I do see Dr. Bruno's hand up. I'll defer to you on that. Also noting that we do need to stay on agenda.
That's what I was going to say. In the interest of time, let's get Dr. Bruno's question and then see if we can get to some sort of consensus on being able to pare this down. Dr. Bruno?
Thanks so much. Yeah, I definitely agree with Dr. Rome that patient out-of-pocket costs should be a factor here. And I also want to note that, my current federally qualified health center, I see about 10% of our patients are uninsured, about 6% of patients in Oregon uninsured. And oftentimes their out-of-pocket costs are going to be higher because they don't have the ability to take advantage of many of the obviously any insurance, but also any of the coupon programs. Sometimes 340B pharmacies can allow uninsured patients to access insulin at lower cost, but a lot of times these are the cheaper insulins, the 70/30, and some of the sort of older insulin products. They're more affordable. So I just wanted to have that consideration in here because it's not really part of, I think what we're able to access from our databases. And then also sort of wanted to agree with the approach of considering first those that had the most sort of claimants, and then looking at some changes, price changes over the last 2 years. So, for me, I was looking at some of the highest claimants that had like the highest percentage changes over the last year to help sort of identify some of the more concerning increases there as a way of filtering. I just wanted to thank you very much.
Thank you, Dr. Bruno. So currently right now, the way I've kind of written it out for myself to look through this, it's if we remove biosimilars into therapeutics, there is we look at the direct patient, the highest out of patient pocket expense, highest utilization, and then the most claimants. Correct? Is that where we're at right now in terms of our pare down?
That is my understanding.
Okay.
Patterson.
What was that, Vice Chair Bailey?
Just saying, that was my understanding as well.
Okay. So now that we're at those four, where do we end up with if we use those kind of four practices right now, and then how would that look?
Chair Patterson, I can filter the data on those that do not have a high utilization in terms of claimants. If the board has kind of a guideline or a thought, or if they just simply want to sort by the number of claimants and view the data that way.
I think it'd be able to being sorted in that methodology would probably be best at this time.
And I've currently applied a filter to filter out any that the change in, oh, sorry, that's overall spend. Let me fix that real quick and do the per patient. And I see Dr. Bruno has his hands up.
Oh, yeah. So I'm just looking at what you had just done there, and it looks like, Traceba, Flex, and our Flex Touch rather is, rising to the top here in terms of like, high number of claimants, high cost, and actually has an increase in the percent change per patient spend from 21 to 22. So that would be, one that I would keep a close eye on.
So I'll just say that has a generic though. So that I think the reason that you're seeing that is because now there's a generic out for it. And so the original branded agent had a price increase to try and capture a little bit more dollars. But just to kind of color that in a little bit.
Vice Chair Bailey. Greatest speech ever. You're on mute though.
Great, thanks, Chair Patterson. In trying to find guidance on the amount of products that we really that's achievable for the team to be able to review. Is there any guidance for us members today on what is keeping in mind the other list that's being worked on? Is there any guidance on like an optimal number we should be, or a maximum number we should be keeping in mind so that we can get to a number today?
Sure. Vice Chair Bailey, I appreciate that reluctant to just give you a maximum number because we serve you as the board. In terms of manageable workflow and the statutory requirement to identify one, I would think that something in the neighborhood of a half a dozen. Obviously, we want to do a substantial and meaningful review on these, with the same time noting that the criteria is specific to overall spend, per patient spend, and patient out-of-pocket costs. So understanding the variability of dosages per individual that uses insulin as one variable, understanding the number of claimants informs all of this conversation. Again, excuse me, reluctant to give you an exact number, but I'm going to say I think a half a dozen to identify one or more would be a realistic number.
So are we then? So then let's add overall. We've already got overall spend added to the filtered here.
I have not filtered on Chair Patterson. I have not filtered on the overall spend.
Let's add overall spend to the filter and see where we're at with in terms of just what we get.
Is there a threat? My apologies. Is there a threshold amount you would like to filter out?
Give me the 10 highest, I guess, or what's the price? What's the highest 10 or? Oh, wow.
Yeah, the one other piece just on this list, just to be very cautious, is some of these products might want to bundle, right? So like the pen and the vial for the same product, you might want to consider together. And I know that that's aggregated on another tab, Amanda. I think it's aggregated even more. It's aggregated for the biologic and all of its biosimilars. So just to put it out there that like, if you're going to evaluate, insulin degludec, for example, I would evaluate all the different dosage forms of it.
But we're already removing the biosimilars as well. So that would negate that, correct?
Yes. No,
Okay.
that's right. I'm more just saying how to present the data.
Well, I just want to make sure that we're following kind of what we're looking at here. We're looking at the patient cost, patient out-of-pocket cost. We're going to remove the biosimilars and the therapeutics. The highest, we're going to look at highest utilizations. We're looking at most claimants, and we're also looking at the overall spend at this time. So if we did,
and I think the overall claimants and the overall spend are probably going to be similar, right? They're going to line up well. Like I think
they should, but we just want to we're trying to get down so it's manageable. And so I think having just using that information to be able to pare it down would suffice. Chair Bailey, Vice Chair Bailey.
Oh, please have the two clinicians that have their hands up go first.
Okay. Daniel.
And we have there's a mention about the insulin companies reducing the price by January 24. It might be helpful to have a flag for which products are getting these steep reductions in price, because I think would be a useful exclusion criteria too, which
Yes,
sounds like it's a lot.
Thank you, Dr. Hartung. We can add that as a flag. I do want to note that I think some of the price reductions only apply to patients on commercial plans. So some of the price reductions may not be for...
Yeah, so there's two different sets of price reductions, Amanda. There's WAC price reductions, the actual price reductions, and then there's price reductions that are not really price reductions, but more just discount cards that they're offering for commercial patients. I would not consider those. Those are similar to what they're already offering, but the ones where the list price is actually falling, that's a smaller number of, it's a smaller subset of drugs, but those are real price reductions that will affect all patients because it'll affect the entire supply chain cost of the drug.
Let's look at Amy.
Yeah, I just, you know, as we're kind of rolling through the things that we're going to filter, I want to be really careful in the order that we filter things. Because if we filter things in a way that's not super thoughtful, we're going to get a list that doesn't necessarily reflect the things that we've discussed today. So I would caution that the order in how we choose to filter these things is really important.
I don't think we're selecting order wise. This is just going to be our composite group that we're going to, because remember, we're trying to pare down as best as possible, and we're going to only be making recommendations to the legislator. And as we have to do our best with the limited time and resources that we do have available at this time. And I think just being able to pare down so that we can make this manageable for the team is very important. Vice Chair.
Thank you, Chair Patterson. So along kind of the message that you were conveying, I guess I'd like to ask, you know, in specifically the clinicians here today, does it make sense given the number that we're kind of keeping in mind, or what's achievable for the team, of perhaps keeping in mind the filters we've discussed, trying to pick like 2 from the long acting, rapid acting, and intermediate? I'm not suggesting that is the right answer, but I guess I'm just curious what the clinicians on the team here today would think about trying to do it that way. Keeping in mind the claimants, the patient out-of-pocket spend, and I guess any other things we discussed. Is that something that makes sense to anyone here?
I can kind of respond to that, if it's okay.
Yeah, absolutely, Dr. Bruno.
Okay, so I mean, I would say that the long actings tend to be more expensive than the intermediate and rapid actings overall, and especially the ones that have the combination with the GLP-1 agonists, things like Ziltrophy, et cetera. You know, those are going to be the ones that are going to be sort of higher on my list because they're meds that are very helpful, but are also very inaccessible for many of the patients that I take care of. So, I mean, I hear what you're saying, kind of, you know, equitable across those like different, like short, intermediate, and longer acting. But for me, I think it's the longer acting that I tend to be a little bit more worried about in terms of price increases.
So what if we took 3 of the longer acting based on that criteria, 2 of the rapid, and then 2 of the what's the third category?
We have a short acting intermediate.
Yeah, and then 2 from the short acting intermediate. Would that suffice? So 3.
I think that's what Vice Chair Bailey was suggesting is having.
Yeah, I was just hearing Chair Patterson, I think, listening, Dr. Bruno, to your suggestion and appreciating that those are the long acting are harder to access, like adding another one for review. At least that's the way I heard his response.
Yeah, we're just going to add 1 extra for review.
Gotcha. I mean, yeah, if for example, you know, if a patient comes in and new onset diabetes and they are coming in with a you know, an A1C of, like, let's say 10, and, you know, warrants starting insulin, I'm not going to usually typically set them up on like multiple times a day insulin. Like, you know, we're going to try and start with like the once a day, like long acting, because it's just easier and it's like more likely patients are actually going to do it. You know, so from like a practical standpoint of diagnosing people with diabetes and trying to get them onto insulin, you know, I think there's a preference there for like the longer acting products, just simply because they're easier to use.
Ralph?
Thank you, Thank you, Chair Patterson. I'll note Dr. Rome did have to drop off. I just want to flag the importance, I think, of what Dr. Burns noted, and that is the sequencing and application of these filters. I think she makes a very important point, because at one point when we were pretty far into this conversation, I think Afrezo was up at the top, and to that point, once the filters began to be applied in different methodologies, that drug disappeared. And that is certainly not an indictment of that drug. That is just recognition that it was on a list and stressing the importance of the sequencing of filtering.
Amanda, go ahead.
Thank you, Chair Patterson. Sorry, I didn't have the option to raise the virtual hand. Based on the suggestion that maybe we look at a few from each category, would it may be beneficial to the board that I clear the filters, we filter on each category at a time, go through the filters and criteria that we were going to filter out and sort by, and just kind of focus in on a couple group and then pick top 3, top 2 that the board would want to review from each of those categories? Would that be beneficial to the board?
I say we go along those lines. Let's go. So 3 for the long acting, 2 for the short, and 2 for the rapid or intermediate.
I will start with the long acting, since Dr. Bruno had expressed an interest in that. None of these appear to be on the CMS list. And would the board want to filter out anything that had a decrease in the per patient spend from 2021 to between 2021 and 2022?
Is there any appetite?
I'm sorry, could you repeat that?
I was asking, is there any appetite from the board to remove anything that had a decrease? Which it looks like most of them did. Vice Chair Bailey, sorry.
I can just say as a non-clinician, it would seem like removing ones that did have the decrease, especially some of the significant ones, might just make sense. I guess it's going back and looking at the number of claimants to make sure we're doing something meaningful when we look at things. So again, a non-clinician opinion would be to remove ones that had a decrease in overall patient spend.
So if we filter out the ones with the decrease from the long term, that will lead us with 4.
Dr. Burns also has her hand up. I want to make sure to mention.
So I think this is a good place that that Dan was talking about, where there's some changes in prices because there is a generic for Tresiba on the market now. And so although we have a lot of claims and claimants there, and we saw a % change in overall spend from 21 to 22, if you look at 22 to 23, I guarantee you will see a decrease because the generic is on the market. So in that sense, I'm not sure that this, because the other 3 have really low claims and claimants values in comparison. So.
Dr. Bruno.
Right, I agree with that, and also, you know, Siliqua and Ziltofi were newer at the time, so they probably had less claimants. But you know, I think those 2 would be ones I would be very concerned about, especially because of the price and the price increases.
For long term, would it be okay if we had the team go back and analyze these 4? And start to review these 4?
Chair Patterson, are you suggesting that these would be the 4 insulin, like the insulin subset list that we would review for affordability?
So we said, you know, we wanted to try to get some long term, some short term, and some rapid. These 4 would be for long term, because obviously there are other mitigating factors to weigh in on, such as there might be an alternative that has been on the market that just is not seen in this data right now.
I think, Chair Patterson, I think what I was hearing from the others was anticipating that Tresiba may not make the list based on what I think Dr. Burns had just said. So if we understood Dr. Burns right, I might suggest carrying just the Soliqua and the Extolfi as the two, and I'm seeing a virtual and a physical thumbs up from Dr. Bruno on that, if folks are amenable to that. And showing hands, I think of.
Was that showing hands or is this?
No, sorry, mine was a comment.
Okay.
The only thing I wanted to say was, since I was the one that suggested we look at the percent change in overall spend, I want to make sure that the number of claimants, we don't lose anything, that because I threw that out there, it might be just worthwhile to relook at the number of claimants, so that suggestion of mine, somehow we don't lose a lot of volume of claimants somehow. But again, I defer to if the clinicians felt that list was appropriate, then. So Amanda, or thank you for showing that.
Amy?
Yeah, I would suggest that we keep at least one long-acting non-combination insulin on the list, even if that means that we keep the Tresiba with the generic. I just think that it's having two combination GLP-1 and long-acting insulins is.
So yeah, so that's why I said at this time, my
Yeah.
suggestion, we just carry over these 4 to be reviewed, and then we can make decisions later on, in terms of the long acting, just in the interest of time right now. But if we just want to at least carry over one of them, that is also fine. So we'll carry over at least 3.
Chair
I like
Patterson, I believe this will require a vote.
Yes, then that's why I'm just trying
Okay.
to get us down here. So when it comes for the long acting, is there anyone that would like to have a motion?
Sure, Chair Patterson, I'll move that we consider Tresiba, Zoltofi, and is it Soliqua? Sorry, those bottom 3 there to be considered.
All right, is there a second?
I second the motion by Dr. Bruno.
All right, so we have a motion on the floor to accept for long-acting Toshiba, Sequila, and Zitofi. Amy, Melissa, call the roll.
Daniel Hartung,
Aye.
Amy Burns,
I have a quick clarification. Sorry, Chair Patterson. Are we including the Flex Touch in this?
No, we would not.
Then nay.
Do you have an amendment?
I would include the Flex Touch. Like if one of Dr. Rome's suggestions was bundling the vial and the pen. So I think that would be an appropriate way to go here.
So yeah, so if you would like to make an amendment to have all 4 carry over to be
Sure.
reviewed, that is also something we can do.
I'd like to make that amendment, Chair Patterson.
There's an amendment now being proposed. So we have to finish the vote on the first one in order to make the amendment on the second one. Okay, so let's finish out the vote to have these 3 with an amendment to be subsequent after, correct?
okay, I'll finish the vote. Amy
Okay.
Burns,
No.
Richard Bruno,
Yay.
Shelley Bailey,
Nay.
Akil Patterson.
Nay. So the
The
first motion
motion fails.
has been defeated. There was an amendment put out to add the 4th. All right, so we would carry over.
Okay,
Yes,
I second the amendment.
second the amendment by Dr. Bruno. Now Melissa, call the roll.
Daniel Hartung,
Aye.
Amy Burns,
Aye.
Richard Bruno,
Yay.
Shelley Bailey,
Aye.
Akil Patterson.
Aye.
Motion passes.
All right, so we've gotten through the long acting, so we've got 4. Let's move over to the short acting.
Chair Patterson, if I may, could I ask if there is any opposition to extending today's meeting by 30 minutes, noting that I need to ask that broadly of the entire board participating today. If anyone is unable to, we would lose quorum. It is imperative that we do get through several other items on the agenda today, and I want to make sure we have opportunity to do that.
Is there a motion from the committee, from the board to extend by 30 minutes, seeing that all members would be able to attend?
I'll make the motion.
Amy make the motion,
I second the motion.
seconded by Chair Bailey. Okay. By acclamation, if there are no dissents, we would extend the meeting by 30 minutes. Any dissent? Hearing and seeing no dissent, we will extend the meeting by 30 minutes by acclamation. Okay. Pressing forward.
All right, so if we filter the short acting on those with an increase in the per patient spend between the years, we get two, which are just two different forms of Novolin. So essentially one drug. And let me just double check that version of Novolin. It does show some price reductions per Dr. Yuan's slides. I can also remove the filter on the percent increase. It can just be more of a guideline for the board than necessarily a hard filter, depending on the board's wants.
Amy?
Yeah, thank you. Amanda, I have a question. It's so were there any filtered out for the IRA or CMS? No. Okay, thank you. That was
Vice Chair Bailey? Mute button.
Sorry about that. Thank you, Chair Patterson. So you referenced, Amanda, that the Novolog was already on Dr. Yuan's list, correct? Was Humulin, the Humulin R U500.
Concentrated.
I do not believe I saw the Humulin on the slide for those that frequently apply for price reductions.
Or the quick pen.
Mhm.
I wanted to. Thank you.
I'm sorry, go on.
Nope, I just wanted to confirm. Thank you.
So maybe potentially filter out the Novolin Rs.
That
which
was
will be-
and that's a suggestion that I was kind of headed toward with asking that question. Thank you.
Ralph? You're on mute.
Thank you. That really is where I was going as well, in a potential staff recommendation, consistent with Vice Chair Bailey's comment, and that filtering on column L, if you were to look at the cost of those, in essence, the two that remain are at least twice the net out-of-pocket per patient cost. So that was the premise there. Thank you.
Okay. Honestly, it looks. Yeah, is there a motion for this one of which ones we want to carry over to be reviewed?
Vice
Vice Chair Bailey, you may be on mute.
Thank you. I was just going to suggest that we include all three, because per Dr. Burns' notation in the previous vote, that, you know, kind of combining the RU 500 quick pen and the non-quick pen. Or I guess, are those both a concentrate? I thought they were, but that was going to be my suggestion.
And only one was listed as concentrate. Dr. Bruno?
Yes, thank you, Chair. The The middle one is the one that has the price increase, percent change in overall spend, 1%. So that would be the one I would look at. You know, the U500 is 5 times more concentrated than the typical insulin U100. So this is used for particularly challenging diabetes cases. So it's not as commonly prescribed.
Vice Chair Bailey.
So then I'd like to amend my recommendation to see if we could include the Humulin R and the Humulin R U500. Kind of along our discussion lines of trying to have more than one in each category.
Okay. All right, well then, would you like to make the motion?
I would like to make a motion to vote on adding both the short-acting Humulin R and the Humulin R U500 quick pen.
All right, we have a motion on the floor. Is it seconded? Am I frozen? Is it seconded by anyone?
Chair Patterson, you're not frozen. I see Dr. Bruno with his hand up.
Okay. There's a motion on the floor that we would make the staff would review Humulin R and Humulin RN 500 quick pen. Is there a second to that motion?
I'll second.
Second by Richard Bruno. Melissa, call the roll.
Akil Patterson.
Aye.
Did that backwards. We'll go backwards. Shelley Bailey.
Aye.
Richard Bruno.
Aye.
Amy Burns.
Aye.
Daniel Hartung.
Aye.
Motion passes.
All right. So we will have two Humulin R, Humulin RN 500 are being moved on. And then let's go to the rapid.
With the rapid, we do have on the price negotiation list from the CMS, Novolog and Fiasp. And so we can,
That's correct.
sorry, the audio cut out a little bit, but we can filter those out.
Yeah,
And that will, and there are various forms.
Vice Chair Bailey.
Thank you, Chair Patterson. So I guess the other question that I would like to propose is to make sure that anything from the rapid acting list that was also on Dr. Yuan's list of drugs that had the price decreased, that we remove those as well to be consistent with the other types of insulin that we were discussing.
All right, so we will remove the forms of Humalog from this list. And we will remove Novolog, which looks like it is not on that list. Let's see.
Just to clarify, Amanda, I recognize that, oh, it's Humulin, not Humalog. Okay, sorry about that.
All right, and I think I've caught everybody. So that narrows down the list considerably. And if we do want to filter on those that have, let me go to the per patient spend, increased in need per patient spend, I think I'll collapse this field. Any of those that had an increase, that narrows down the list to 7. And kind of along the lines of some of the previous votes, we can consider like insulin this far together. And let me double check and make sure that is not on a reduction list. And yeah, so that narrows down the list a bit.
Amanda, could I ask you to sort by out-of-pocket cost per patient, please? Thank you. Board, I would ask you to consider perhaps as a staff recommendation if there is what you see to be a natural kind of cut list or line in this conversation based on patient out-of-pocket cost. Vice Chair Bailey.
One thing I guess wanted to highlight was the number of claimants. It seems like in our previous discussions, we've eliminated those with low claimants. I would like to propose that we eliminate the top two because of the low number of claimants.
I thought we were adding that filter anyway, but
Oh, possibly, maybe things hadn't caught up, but I just wanted to mention that.
For clarification, Chair Patterson, we could sort by it, but the board did not identify like a kind of a threshold, like say if it's 50 claimants, 100 claimants, that
okay.
they would like to exclude from review.
All right. Amy, did you still have a question, or was that just, would it kind of get resolved?
Vice Chair Bailey had the thumbs up. That's what I was gonna say too. So cool.
Okay. So where are we at right now?
So that reduces the list down to 5, with the two most expensive based on out-of-pocket cost per patient in 2022 is Liamgia and its quick pen form. And it looks like it's a pretty big jump between the per patient out-of-pocket costs when we look at the other three, that they're about half the amount.
Vice Chair.
Thank you, Chair Patterson. So just to confirm, kind of being consistent with what we did with other insulin types, I am reading this as basically saying that we have 3 drugs we would be looking at here, correct?
It's really up to the board's discretion.
Okay, I guess I'd like to ask my peers here on the board then, are we kind of, if we combine the insulin aspart with the insulin aspart pen fill, the Aprita Solistar, and then the Lumavic quick pen and non-quick pen, that seems in alignment with what we were doing with other insulin types. Is that correct?
Yeah. Yes.
Yeah.
We add the top 3. Amy.
Yep, that was what I was going to agree, that that's what my understanding and what I think makes sense to do.
So just looking at the top, well,
So
the Peter Solo Star only has what, 14 claimants and 100 claims. Yeah. All right. So if we were so let's look at it. So we would probably be best served looking at, I mean, top 2, top 3 here. It's up to the board, but the price gap seems very high. Dr. Bruno?
Yes, I agree with Vice Chair Bailey and Dr. Burns. We could collapse the top 2 and bottom 2, and I would just recommend we would consider all 3 of these. So I'll make a motion to include all four of these.
There's a motion on the floor by Dr. Bruno to include all 4.
I'll second.
Second by Amy. All right, so we are at 11. Yeah. So
Would you like a roll call, Chair
Roll.
Patterson?
Huh?
Would you like a roll call?
Yes, please call the roll.
Daniel Hartung,
Yes.
Amy Burns,
Yes.
Richard Bruno,
Yeah.
Shelley Bailey,
Yes.
Akil Patterson.
Yes.
Motion passes.
Motion passes. All right, staff, you're at 11, so
All right, let's see.
All right, if I may, Chair Patterson, apologies, Amanda. Just Chair Patterson needing to address the agenda and timing for just a quick moment. Let us continue with this conversation and then move into the policy recommendation discussion with a hard stop on that at 11:45, with the necessity to include announcements. And we have a fair number of people signed up for public comment. I will, in lieu of the board survey conversation that we will need to table, I will need just a couple minutes to make some broad announcements. So thank you.
And
Thank you.
just to clarify, Ralph, this conversation is to include the orphan drug conversation.
Correct. And we're going to pivot into that right
All right.
now.
Perfect, thanks.
All right. All right, so we want to pivot to the orphan drug conversation. Is that correct, Ralph? All right,
Correct.
I'm going to pull up our working drug list onto the screen. Thanks to feedback that we received on the orphan status that we had defined for some of the drugs, we consulted with some outside consultants and partners to remedy a few drugs based on additional information and context. We have added a changelog tab to the document to note any changes to any of the drug statuses or values in the fields. The changes were Biktarvy was previously listed as orphan only, and it was updated to both orphan and non-orphan. The buprenorphine or Suboxone was previously listed as orphan only. We corrected this to no. Eylea was, we updated the exclusivity expiration date from yes to no. Maviret was previously listed as an orphan only. We updated both the orphan and non-orphan statuses. Shingrix was previously orphan only. We have corrected this to no. And Ultomiris, the updated exclusivity expires within 18 months, no to yes. And we did want to note that the FDA did announce a therapy or biosimilar for Stelara. So we have updated that information with the announcement of Wezlana's approval. With that, because of the change to those orphan status designations, we did need the board to confirm that we could revise the subset list to remove those that we have since identified as orphan only and include any that are both orphan and non-orphan. Additionally, we do want to check to see if the board wishes to exclude drugs that include any orphan statuses.
And Amanda, if I can speak to that as well for just a moment to the board, and some of this conversation about resetting on orphan drugs and the potentials to the staff recommendation to remove any of those. While statute precludes us from conducting reviews on drugs with designations to treat rare diseases, it did not preclude us from reviewing those drugs for other indications. When we did write these rules together with you, the board, we had hoped to be able to get granular enough in our data analysis of APAC data to slice and dice utilization to any given diagnosis code. We have found that to be extremely difficult. To that point, additionally, off-label prescribing would further cloud that analysis. So I do want to just make that known to the board. Thank you, Amanda.
My pleasure. And thank you, Ralph, for the clarification. Vice Chair Bailey?
Oh, I guess before I make my comment, Amanda, did you have more you were going to share with us before we open our discussion up? I didn't want to interrupt you.
Oh, no, that is pretty much the summary of the changes that were made to the sheet and just getting the clarification and confirmation from the board.
Okay, thank you. Then I'll go ahead and make my comment. So I guess what I'd like to say is, given the information that Ralph shared related to the lack of data to help us figure out when medications are used for non-orphan purposes, and it seems to make sense to me that we would remove both orphan and those drugs with non-orphan designation.
Was there any other feedback from the board?
Chairperson, that will reduce the list down to 20. Additionally, if the board would wish to filter out the drugs that are on the CMS's negotiation list, that would further reduce the list down to 16 drugs for consideration, which may be a more manageable list for the board to be able to do an in-depth review of each drug.
Vice Chair?
I guess from my perspective, given that our insulin list was a little more robust than maybe is feasible for the team, it would make sense to me to also remove any of the medications from the CMS list as well.
So right now, I think we would. Ralph, does this require a vote? Can we get some confirmation? You're muted, Ralph.
Chair Patterson, should the board accept these staff recommendations? Yes, that would require a vote. At that point, we would move that list forward formally into the 0020 affordability review criteria process.
All right. Is there a motion from the board?
Looks like Dr. Bruno already raised his hand.
Go ahead.
Sorry, point of clarification. We're suggesting remove the FDA list meds, but also what about the orphan and non-orphan status? That was already filtered. Do we need to vote on both of those, or is this a vote for both?
Voting on
in totality of both. Sorry, Chair Patterson.
Yes, we would be voting on all of it right now, saying that we would be accepting the recommendations of removing the CMS and the orphan and non-orphan drugs.
Okay, is there room for discussion here?
Yeah, absolutely. I mean, there has to be a motion. In order for discussion to happen, we must have a motion first. And so so if there's a motion made by Vice Chair Bailey, then we can have the discussion on that specific. So Vice Chair Bailey?
So you said we can have the discussion if I make the motion.
So yeah, so making the motion opens
I
us
will
up.
make the motion to accept the staff's recommendations, which specifically means to remove not only orphan drugs, but those drugs with orphan and non-orphan status because of the lack of ability to trace it all the way through to see the off-label use, as well as removing the drugs from the CCO list or the CMS list.
All right. So there's a motion on the floor. Is it seconded? So there's no second at this time. Richard, did you want to have discussion around that motion and to amend it in some way?
Well, I guess my concern is if we do remove those both orphan and non-orphan status drugs, we will remove some of the ones that I personally feel are worth considering. Although, you know, I do want to move this process along quickly, so I won't stand in the way because there are so many others that are, you know, pretty hefty offenders here. So yeah, but and it helped. Vice Chair Bailey's most recent comment did help with the traceability piece. So I start to understand that a little bit more, and thank you for that.
Daniel?
I mean, I share that concern as well. The issue of the drugs that initially are approved with orphan designations and then go on to have many other non-orphan designations, which drives utilization and highly prevalent conditions where affordability is an issue. This issue about tracing it back to understand differentiating affordability across orphan and non-orphan conditions. It's a little unclear what that means, but I think that this is our first process going through this list. So I think that I take staff's suggestion to heart in terms of they're doing the kind of the heavy lift to try to do that. And so maybe after this first go around and we find that maybe we in the full affordability review, whatever that looks like at the end of the day, if we decide that after this first thing we can handle looking at these drugs that have both orphan and non-orphan designation. Maybe we can revisit that in the next cycle. So I see kind of both perspectives, and again, just for expediency, I would support this motion of excluding them at the, at this point, just for, efficiency.
So there's still the motion currently right now. So is it seconded by anyone?
I'll second it.
Richard Bruno has seconded. Any further discussion? If not, call the question. Melissa?
Daniel Hartung,
Yes.
Amy Burns,
Yes.
Richard Bruno. Could you repeat that? I'm sorry. Thank you.
Yes,
Shelley,
yes.
that's a yes. Thank
Yeah.
you. Shelley Bailey,
Yes.
Akil Patterson. Akil Patterson.
Yeah, the motion will pass. I will abstain only because I do feel that there are things, components to this that I'm not fully aware of, so I'm just going to abstain, but the motion does pass.
Thank you.
All right. Next order of business. I'm sorry, I'm switching devices here from one to the next. The board survey overview. I'm sorry.
Oh, you're good, Chair Patterson. We are going to move into discussion on policy recommendations. Courtney and I will facilitate this. First, a note of gratitude to the board for what was a difficult conversation, both on insulin and identifying drugs to move forward for affordability reviews. And thank you, Amanda and Courtney, of course, for your good work there. Courtney and I will take you through this together. And I think Melissa, not sure you got the right slide there. This is the policy recommendation discussion. I think you may need to go backwards. So I'll keep going while those slides pivot. Thank you. So based on responses to our member survey about recommendations, staff recommends that we provide a cut list at those that for discussion and consideration of policy recommendations to the legislature that received 4 or more votes. Courtney and I will provide a brief overview of those and ask for board discussion and a vote to advance these for staff preparation into the final report to be approved at the December meeting. Courtney and I will provide, as I noted, a brief summary of each of these and a little bit of commentary, and then open for board discussion, if you will. And Melissa, if you can go to, I think the Word document probably is the best place to facilitate this conversation.
And just for clarification, the board should have reviewed at least the RAC summary. This has been the 2nd month of this, so having a pretty good understanding of the policies that have been recommended by the public. And again, we kind of have to move through this quickly to keep us on time. But as soon as Melissa can kind of show the overall summary. Again, the board was provided kind of a survey. And so you've collectively already identified the important policies that you've provided. The top 5 that were shown in the graph previously pretty much identifies to lower the limit of the insulin, which Ralph will be touching base on, unless Ralph, you want to start off with those.
Yeah, we'll
Why we wait
start
for
with,
Melissa to pull it.
yeah, we'll start with this one. Melissa, I think we're looking at about page 38 of 53 or thereabouts in the meeting packet, just the subject line summary of proposed policy recommendations submitted to the board. So to speak through these fairly briefly, the lower insulin, thank you, the lower insulin cap or $35 limit and decoupling it from inflation. Inflation has generally been higher than expected in 2023, as we are all acutely aware, leading to faster growth in the CPIG and faster than anticipated growth in Oregon's insulin cap, which will be $85 during plan year 2023. Concurrently, additional generic insulins have been brought to market, and prominent manufacturers will begin to lower their prices. Due to this, and if you'd keep going, Melissa, the $85 cap in 2024 will be significantly higher than the actual cost. Keep going, please. For most insulin, keep on keeping on. To, I think the one that's got the PDAB.
Yeah, I don't think that, Melissa, so in the material packet for that was posted on page 38 is where the summary starts. So again,
Yep, and I'll keep us moving in the interest of time. The bottom line on this one, lowering the insulin cap has the potential to lower out-of-pocket cost for consumers who rely on more expensive insulins with relatively little impact on overall payer cost. Given the reduced list price for common insulin laws, Oregon's law as currently written does not apply to most insulin purchases. Courtney and I are going to run through these top 4 or 5 together, and then we will open for discussion. Thank you, Melissa.
Thanks,
Courtney, go ahead.
Yeah, so the next most populated request was to look at the changes to the Oregon generic substitution requirement as applied to the biologic products and biosimilars. So Oregon already has a law that pharmacies can substitute therapeutic equivalent generic pharmaceuticals, and there's some specific language on how that process happens. I think one of the things that really brought this up as a recommendation from both OCAP and AHP was that it provides the wider adoption of biosimilars to come forth. So it would be more of a higher expectation for that replacement, which can also increase the adoption of the biosimilar in general for the savings for the healthcare system as a whole. So, and again, this was the number 2 recommendation overall for the board. Back to you, Ralph, if you want to cover number 3.
Yeah, thank you, Courtney. So number 3 was a recommendation to support recommendations in the 2023 Secretary of State CCO audit, and it relates to pharmacy benefit managers. Number of stakeholders weighed in on this. The recommendations included expanding OHA's oversight of Medicaid PBMs, adopting a different PBM model for Medicaid, such as a single PBM or a fee-for-service approach, potentially mandating a universal preferred drug list with uniform requirements and utilization controls, adding a Medicaid PBMs to DCBS's oversight of commercial PBMs, as existing protections for consumers and pharmacies do not apply to the Medicaid space. This could expand those. Additionally, the recommendations included requiring PBMs to act as fiduciaries to carriers and consumers, expanding PBM transparency, which is discussed later, and studying creation of a state prescription drug program. So look, practical matter, this audit was robust and covered a lot of different aspects of the Medicaid pharmacy delivery system. Many of these are extremely complicated in their approach, and to that end, some may even require federal permissions and waivers, while others are more straightforward. To that point, I do think there are several straightforward, which include, and I will just revisit these: 1, expanding OHA's oversight of Medicaid PBM contracts, adding PBMs to DCBS's oversight of commercial PBMs, requiring PBMs to act as fiduciaries to carriers and consumers, and to study the creation of a state prescription drug program. Ultimately, this is a board decision. So we will leave that for discussion shortly. Courtney, back to you on the next one.
Yeah, so the next one that was voted has to do with the cost and fee a proposal, which is very similar to the House Bill 3013 that was presented at the beginning of long session this year. It did not make it through, though. There's various benefits to kind of having the oversight for the reimbursement model. However, there's also risk, such as the cost of the drugs for both the individual and consumers to the system can overlap and can create some challenges to collect the net impact of how those reimbursements from the PBMs will contribute to the overall process and system. This also would include having a little more oversight to for the cost administrating, the benefits for the CCOs or the coordinated care organizations. And then consumers with commercial coverage could see higher premiums and to out-of-pocket cost due to this, if it's as one of the risk factors. Otherwise, there are other benefits to having that cost to fee for the reimbursements for pharmacies. And Ralph, you want to go to the fifth one, please?
Yes, thank you, Courtney. So the next one being expanding PBM transparency requirements, supported by the Chronic Disease Coalition, Pharma, International Cancer Advocacy Network, all proposed expanded transparency for PBMs, pointing to the Secretary of State audits. As noted, Oregon will begin collecting PBM data in 2024. Following passage of Senate Bill 192, which requires PBMs to report certain information about rebates and how money is allocated to DCBS, in fact, to PDAB sibling program, the transparency program. To that point, my 2 cents to you, board, would be let's see what comes in over the next year with this new PBM reporting requirement, and also track a number of pieces of legislation in the U.S. Congress right now that's moving through the Senate Finance Committee as it relates to pharmacy benefit managers. As a reminder to all of you, what the process will be with DCBS beginning next year, for which the Rules Advisory Committee I mentioned, that the PBMs will begin reporting to the transparency program aggregated dollar amounts of rebates, fees, price protections, and other payments that PBMs receive from manufacturers, and how that information and how that money is returned to carriers issuing benefit plans, to enrollees at the point of sale, or retained by revenue for the PBM itself. So I think, to be candid, that we should begin collecting that data first, and then proceed once we can make more meaningful, informed recommendations there. So I believe that is the totality of those that received 4 more votes. If we can, Chair Patterson would like to open for discussion for the next 7 to 10 minutes, if you will, to see if there is heartburn or consensus around moving these forward. And that will be to advise staff to go ahead and formulate these as formal recommendations for your approval at the December meeting.
Thank you, Ralph. I before we even get started, I think that there is quite to look into for each one of these. And I think us going one by one would probably be in the best interest of the board. Trying to group them all together, I don't think is in the best interest of the board or its membership at this time. So I would like to open this up for discussion for the next several minutes. If there are anything that are causing massive heart palpitations, please let me know. And for me, that is number 3. Number 3 is based off of the Secretary of State's PBM audit. It is very robust. It, like you said, it has parts in which we could be getting done quite easily, or relatively easier than others. And I think it just right now, it's as some would say, it's not ready for prime time. And so I think we would need some more time to go through each one of those. So number 3 for me, I'd like to make sure that we just kind of definitely table that one and probably come back to it at a later date. But I'm listening to other board members. Vice Chair Bailey.
Thank you, Chair Patterson. As opposed to tabling it, I mean, because obviously it was something that resources and effort was put into by the Secretary of State for an identified problem. Is there a way, I wrote what Ralph said would be achievable from the Secretary of State report. So I appreciate that maybe not, everything in that report is something that we can look into from a legislative perspective, but keeping in mind that we are missing 2 board members here today, I also appreciate, but could we talk about keeping the parts of the Secretary of State report that are feasible as line items, as opposed to completely excluding it, because it is something that came up with many votes?
So again, I'm not saying we would pull it off, but obviously it is more robust. And I think we just table number 3, continue with the rest of the recommendations, and then we can eventually come back to number 3 in January even. But I think right now that, again, it is very comprehensive and hits very many targeted areas. And so that's just my feeling. Amy?
Yeah, I would agree with tabling number 3. I'm going to go out on a limb and disagree with Ralph and Chair Patterson, your assertion that it was super robust, though. A lot of what they've come up with recommendations, although might be very good to look at, weren't actually supported by the data that they collected for the audit. So I would suggest that we table it as well and look for pieces of it that do make sense and that align with the work that we want to do going forward, and maybe focus on some of the more singular recommendations that we have to consider here.
So we're effectively in agreement to you think it's not robust. I think it is. I just think, yes, we should table number 3 and come back to it at a later date. And we can, let's go for the next several minutes, probably just go through each one of these. So the lower insulin copay limits to $35 and decouple from inflation. Is there an appetite for the board to support this? Amy?
Yeah, I think that this makes sense. This is something the public can understand and definitely affects them right away. I think that this would be very popular, and we have, you know, we have Medicare that's already paved the way. I think that this would be a good thing to focus on.
So is there a motion for the board to support number 1? Is to lower the insulin copay limit to $35 and or decouple from inflation index?
Chair Patterson, if I may, just if we can maybe have conversation to identify the universe, if there are additional ones, just in the interest of time, only doing one vote, if that's possible. Apologies, I'm clock watching, needing to make sure that we have ample time for public comment.
I'm sorry, what were you suggesting?
If we could continue, rather than voting up or down individually on each one, if we could walk through them. It sounds like there's not an appetite to address number 3, but if in the interest of time, there should be appetite for number 2 or 4 and 5, if that could be voted on collectively.
I see no problem with it.
Okay.
And just to make sure, just double check. Any board members that would have an issue with that? All right, hearing none. All right, so number 1, it looks like we do have some consensus. Number 2 is to change Oregon generic substitution requirement as applied to biological products and biosimilars.
My comment would be that since the board members previously provided their votes, and this is one that has 4 or more votes, that we proceed with adding that to the work to be done.
I want to make it clear that the board members did not vote. They ranked.
They ranked their priorities. No, thank you for clarifying the language, Chair Patterson, that they ranked their own priorities from their perspective.
Okay, so we were independently ranked. It was not a vote. So just so the public knows, they were independently ranked and scored. Anyone have any opposition to number 2 being supported? Okay, we'll move to number 2 into our portfolio. Number 3, we have said we will not move forward at this time. We will table that for a later date. Number 4 is require payers to reimburse pharmacies at cost. Is anyone conflicted on this one at this time? I do want to make sure are there no conflicts with this one?
Go ahead, Dr. Burns.
I just had a question. I think this is really intriguing. And I know we had the OSBA come and speak with us previously, but I don't know if they spoke specifically to this. And so did I maybe miss a meeting where we had something that really kind of did a deeper dive on this? Just 'cause it seems complicated, that's all. Not that everything else doesn't, but
Do not believe there was additional conversation about this.
I think it's intriguing and I'm not opposed to it and looking at it. But I would like to maybe understand it a little better.
Okay. Vice Chair Bailey?
Thank you, Chair Patterson. I believe that we should keep this on our list. I do want to recognize that absent of CCO rebate data, I understand that it makes it hard when the state referenced that it could lead to elevated costs. I would just say that absent of having that rebate data, that's hard for us to determine, but I do believe that it is something that should remain on our list.
Any other feedback from members? Well, Amy?
Oh, just sorry, one more thing. I think that this, because I am familiar with House Bill 3013. And I think that is coming back around, is my understanding, in the next legislature, just as kind of an FYI. But it doesn't mean that we couldn't look at something in parallel.
While I'm supportive of the concept, I think I would like to be able to see more detail on for my fundamental understanding of how this would work. But I'm amicable. Go ahead.
Thank you, Chair Patterson. I believe some of this was just what the staff had the bandwidth and to be able to provide, because there is additional insights that could be shared with the board related to how the current fee-for-service model works that would give additional knowledge base and insights for board members.
Thank you.
Great. I guess the only thing I would say, Vice Chair Bailey, as all of you consider these, is remembering and reflecting back upon our statutory charge, and that is to make recommendations to the legislature to lower the cost of prescription drugs. To that point, if there is a nexus between this recommendation and that requirement, I think it's appropriate. Otherwise, I would put it back to you all to confirm or affirm in your own minds that there is a connection between the two of them.
Amy?
Yeah, I would just say, I think that's a good point. And if, this is really just focused on Medicaid, there is not an out-of-pocket for Medicaid beneficiaries. So that doesn't mean that it doesn't affect the system as a whole, clearly, but I think Ralph makes a good point, and we do want to look at it from, the pharmacy counter perspective of the patient as well as the system.
Vice Chair?
Thank you, Chair Patterson. I believe, kind of to follow up on Dr. Burns' point, that it does impact accessibility and it does impact affordability kind of overall, not related to patient copay, but to affordability and access.
So with number 4 in mind, and for the sake of time here, we are supportive. Could we say that we would like to be supportive, but we would need more information and background to move forward with?
Chair Patterson, I think we would be comfortable once, if the board is to provisionally approve these, staff could go ahead and prepare them as recommendations for an ultimate thumbs up or thumbs down vote for inclusion in December, if that
All right, let's look at that then. So provisionally, we will accept these recommendations in number 4. Okay, provisionally. Amy?
I would just say for number 4, perhaps the Oregon Health Authority maybe could weigh in a little bit on this, because it looks like it would definitely affect, their umbrella.
Okay. So let's move to number 5. So again, we're provisionally accepting these and we're just moving the portfolio forward. Number 5, expand PBM transparency requirements.
And Chair Patterson has noted, I think the Department of Consumer Business Services are well on our way to doing that in implementing the provision of Senate Bill 192, which was, as a reminder, part of a board recommendation last year to improve PBM transparency.
Amy?
I would also just like to point out as an aside that there were some recommendations made to the Oregon Health Authority that came out of the SOS audit, and they've already accepted that, and they were around PBM transparency and oversight. So I think that some of this is already happening, as Ralph said.
So we're supportive, but we currently already have this in action.
Yeah, I think that there's definitely movement on this already.
Okay.
Not that that doesn't mean that there can't be more movement. It's just that of the things that were recommended in that audit to the Oregon Health Authority, they were approved and moved forward.
Vice Chair.
Thank you, Chair Patterson. I guess my comment would be, especially since we are not addressing kind of the SOS recommendations at this time, that I think we should keep the PBM transparency component to our list of recommendations to continue to further the work that's being done in this arena.
I would agree with you on that one. Dr. Daniel, Richard Bruno, any feedback? All right, so hearing none, we'll continue with number 5 as being part of our provisional packet for a final vote on in December. Number 6 is
Chair Patterson, we had established that the cut line would be at those which receive 4 more votes, I believe. And that cut line was at number 5, if my math is correct.
That's correct. Yeah.
Thank you.
Right. So just number 3 at this time. Okay.
So exclusion of, if I'm hearing folks right, Chair Patterson moving towards a vote of voting for items 1, 2, and 5. Is that to advance for review and vote at the final?
Yes.
Okay.
1, 2, 5.
And
Chair Patterson, I believe that requires a formal vote.
Wait, were we going, sorry. Were we gonna add 4 as a provisional addition? That's what I at least.
Yeah, let's go 1, 2, 4, 5 is what I do.
1, 2, 4, 5. Correct. Sorry about that.
5 because 4 is moved in as because they will all be provisional, and then we can have further discussions if need be in December. And then number 3 being that it would need more time and clarity, we should hold off till January.
Right.
Chair Patterson, I apologize. I need to clarify that these recommendations are for a final report that are due to legislation by the end of the year. So what is voted on here will be put into a final report to the legislation to be submitted. So I can go with 1, 2, and 5 as yes, and I can provide additional information as best as I can for number 4. But if it's not going to be voted in as the final report for time consumption,
Right.
I would suggest then just voting on 1, 2, and 5.
So Courtney, I think what I'd like to do, if it's okay with Chair Patterson and the board, would be for us to prepare 1, 2, and 5 for formal approval. We will prepare item 4 for a brief workshopping conversation with the board that may be in line edited on screen for their final approval at the December meeting, if the board is amenable to that for a vote.
I believe the board would be I think the board would encourage that.
All right, and Chair Patterson, if you would be so kind as to take a quick vote on that, then we will move on to a couple 3 minutes of important information I need to provide and then to public comment.
Is there a motion to accept 1, 2, and 5 for final passage and number 4 for provisional with further recommendations following the December meeting.
I'll make that motion.
Amy Burns makes the motion, seconded. Do we have Daniel or Richard still on?
I'll second the motion.
All right, seconded by Daniel. Any further discussion? Melissa, call the question.
Daniel Hartung,
Yes.
Amy Burns,
Yes.
Richard Bruno,
Yes.
Shelley Bailey,
Yes.
Akil Patterson.
Yes.
Motion passes.
All right. Let's move on to the next action item there, Ralph.
All right, thank you, Chair Patterson. We will return to the board survey conversation, rest assured, in December. Going to speak for just a few minutes about a couple things that need to be said publicly in response to several comments that have been received from the general public and stakeholders, and that is as following. Given the universe of eligible drugs for affordability reviews following earlier conversations and votes in this meeting ranges from, I think, somewhere between 15 and 20-ish, if you will. We will be releasing a work plan in December to deliver this work to the legislature. At that meeting, we will also be presenting an affordability review template for your review and feedback that has been we've had the help from the folks at Portal to help create that for us. We will also in December be announcing how and where manufacturers can submit information and how long they have to do so. I should note that given our limitations to protect confidential trade secreted information under our enabling legislation, there is no way to guarantee that it would not be disclosed by the media should they attend executive session under their legal right to attend and the freedom of the press. That is a long-winded way of saying manufacturers do not submit trade secreted information as it relates to a drug under review. To that point, all manufacturer submitted information will be posted to our website. Under this premise, there should only be limited need for the board to go into executive session during this process. It will be transparent for everyone to see. For those concerned, I can assure you that this process will be with rigor. It will not be a willy-nilly exercise. As a reminder to folks who have stated concerns about our work potentially limiting access to medications, let me remind everyone, the board does not have authority to set upper payment limits, reimbursement methodologies, or anything else related to rates for either government or commercial payers through employee-sponsored healthcare or any other coverage vehicles. This is not an actuarial exercise. This is, in fact, an analytic exercise. I will also note that nothing in this exercise precludes the board from looking at data points that were weighed lower, and that's specific to the presentation that we were not able to deliver today that Breck prepared. Excuse me, we will do that in December so long as it is feasible. So Chair Patterson, thank you for allowing me the time to share this important information with the general public and stakeholders who have expressed concern that I anticipate hearing in the public comment process. That is all I need to say in the interest of time, although I do need to ask for just a couple minutes of time for the announcement section, at which time I would like to turn it over to Dr. Richard Bruno. And thank you, Chair Patterson.
Thank you very much, Ralph. Actually, we are going to forego the survey and actually head into the announcements. The next board meeting date will be on December 13th.
No, Chair Patterson, I do need to turn my time over to Dr. Bruno for just a moment.
I'm gonna announce the next meeting date.
Okay.
So the next meeting date will be December 13th of 2023 at 9 a.m. Ralph, if you have announcements or if you have anyone you would like to make announcements.
Yes, I would like to turn my time over to the esteemed medical doctor from Central City Concern, Dr. Richard Bruno. Thank you.
Thank you, Ralph, and thank you, Chair Patterson. Just wanted to make a quick announcement that I will have to step down from the board. I'm taking a new position as the health officer for Multnomah County Health Department starting in January. And I just wanted to say I'm so grateful to all of you on the board and the staff for your incredible work in this space, carving out this new path of this new PDAB here in Oregon. And you know, it's been a wonderful experience being able to help craft this pathway forward with you all. And I'll miss it very much, but I know this work is in great hands, and I will continue to support the work that you do, just not in an official capacity on the board. So I wanted to thank you all very much for your ability to continue pushing forward for the people and the great Oregonian, the great people of the state and all Oregonians here. So thank you so much for the ability to serve on this board.
Thank you for your time and your work here on the board, Dr. Bruno. Knowing you for some time now, I am appreciative of the work that you continue to do and that you will continue to do while serving the good people of Multnomah County. So thank you very much. And we look forward to continuing our interactions on a different level with you, but still around the very important work. With that, we are at the public comment section. This is the portion of the agenda for the public comments submitted or requested. As the chair, I will call on those who have signed up to provide oral commentary or testimony and ask them to please respect the 3-minute time limit in which we have set. There were 10 written comments, and is this correct, Melissa? Only one oral testimony?
There are 5, Chair Patterson. I gave you the wrong number early this morning, but we have 5 total.
One. That's what I thought was wrong. Okay, so there will be 5 oral testimonies. Yeah, it keeps coming back as the same one. I don't know why. It was sent at 11:20. So I do not know who has.
We have John Mullen, Brian Warren, Daria McGrew, Terry Lee, Richard Meyer. No, I'm sorry. Let me start. We have 4. Let me start over. John Mullen, Brian Warren, Daria McGrew, Terry Lee. 4 people total.
Okay. Let's start with John Mullen. John Mullen, you have 3 minutes.
And John, I have allowed you to change your camera, turn your camera on and your mic. You should be able to do that.
Okay. I can't seem to turn the video on, but hopefully you can hear me.
Yes, we can hear you.
Okay. All right. Sorry about the video. Chair Patterson, members of the PDAB board, I just want to introduce myself as John Mullen, president of the board of the Oregon Coalition for Affordable Prescriptions, or otherwise known as OCAP. Hope you had a chance to take a look at our written testimony. I realize you're up against a time frame today, and I'll be very brief. I just want to mention that the OCAP board is made up of consumer advocates, unions, health plans, and the Coalition of Communities of Color. We work with a broad coalition in addition to that, including AARP, the Oregon Primary Care Association, Healthcare for All Oregon, and many others. The reason for bringing this up today is to say that there are a number of organizations and individuals that are really watching the work that you're doing. And what we support in general is drug industry transparency, as well as advocating for affordable prescription drugs for Oregonians. Our written testimony includes information on some of the legislation we have engaged in relating to these overarching goals. And specifically today related to the PDAB board about Senate Bill 844, we're pleased to see the high level of professionalism and expertise of the PDAB board members as well as the DCBS staff. We also worked on Senate Bill 192, and we look forward to the development, the report on the feasibility of upper payment limits. That's not due, of course, until September of 24, but we will be watching that. We supported back when House Bill 4005 in 2018 and subsequent legislation and creating the Oregon Drug Price Transparency Program and the development of affordability reviews. And we have been monitoring your discussion, including today. Very interesting, very complicated. We applaud that work and know that it's a difficult process, but we have one concern that the information used to make the decisions on affordability reviews is about information that's about 2 years old now. And then for future consideration, which you talked about just in the previous discussion about the concept we submitted on biosimilar substitutions. Excuse me. I just want to conclude by saying overall, we really want to underscore the importance of the work that you do and the critical issues of affordability for Oregonians. As has often been said, prescription drugs don't work if you can't afford to take them. And so we encourage you to keep the needs of Oregonians foremost in your deliberations and decisions. So thank you very much for the opportunity to testify today, and we look forward to continued work with PDAB. Thank you.
Thank you very much. Next up is Brian Warren.
Hi, thank you, Chair Patterson and members of the board. Brian Warren, I'm with the Biotechnology Innovation Organization. Thank you for the opportunity to provide comment. We did submit a written comment, one specific to the policy recommendation from OCAP on substitution of biosimilars, and a separate one related to some general processes. I want to spend my time today focusing on the policy recommendation related to substitution of biosimilars, and it's unfortunate that I wasn't able to make public comments while that was being discussed earlier, so that we could have a discussion of this in a public forum before a vote was taken. However, a couple of things I want to point out. We have some detailed information in our letter, but I also want to highlight that it is not clear right now what is actually being voted on or what was proposed to move forward, because there was a general recommendation from AHIP in their presentation that was mentioned in the materials, that there be no barriers for biosimilar substitution. And the policy submission from OCAP related to substituting, allowing non-interchangeable biosimilars to be substituted without prescriber intervention, the same way that a interchangeable product can be submitted today. There was discussion in their comments about this, trying to make it more aligned with the state generic substitution law. However, the board memo talks about automatic substitution, which was neither of the recommendations from either of the two public comments that had been received. It also references that generic substitution is done automatically. However, the Oregon statute right now does not require pharmacists to automatically substitute a generic drug. It gives them authority to do so without patient intervention or without prescriber intervention. However, there are other safeguards in the law right now for generic substitution that are not included in some of the recommendations that had come forward. I want to be clear that it is not consistent with federal law to have automatic substitution of non-interchangeable biologic products. The FDA has created the category where those can be automatically substituted, and that is the interchangeable products. They've been so designated by the FDA for that purpose. I will also mention that there is insufficient, there was a lot of talk about insufficient data. There is insufficient data absolutely to support any type of automatic substitution of non-interchangeable biologics for the reference product. Also the materials from OCAP said that they wanted to make this more similar to generic substitution law. However, their proposal removed patient notification requirements and does not include any of the safeguards that surround the generic substitution, including a pharmacist making a professional judgment that this is in the best interest of the patient and that it's safe for the patient, which is something that would at the very least need to happen if a non-interchangeable biologic were substituted. Also, in the event of an auto substitution in particular without patient notification, could be in a patient's not in their best interest when it comes to saving time or money, because there's some examples referenced in the policy summary that was in your agenda meeting materials about some biosimilars not being the preferred drug because, or not being dispensed as often because they're not the preferred drug. So if it's not the preferred drug, it would not be in the patient's best interest to be dispensing that drug to the patient.
Thank you, Brian. That was the 3 minutes. We appreciate your time. Just for clarification, there was no vote on the acceptance of those, just to move them forward for preparation for a December meeting. Just so that there's clarification. We did not vote on accepting those. We just moved them for preparation for the board to then vote on in December. So there will be time.
Okay.
Thank you. Mr. McGrew from Pharma.
Hi, thank you, Chair Patterson, members, Daria McGrew on behalf of Pharma. Appreciate the first I want to appreciate the deep dive on insulin at the top of the meeting. It was very informative. I think the clinical presentation highlights the amount of innovative follow-on research and development that has gone into the insulin market. The insulin today is not the same as it was 100 years ago, and there has been a significant amount of technical and clinical advancement. I think that's very relevant to the premise and discussion of this entire board and all the work of this board. I'd like to highlight a few issues from our submitted comment letter. Firstly, we continue to request additional transparency in the data being used to make board determinations. For example, there is confusion in how the board has clustered multiple drugs into categories and are treating them for the purposes of this work as a single drug. There are some groupings where you have distinct complex biological products that are not interchangeable, treated as if they are the same. There are some groups that you have several distinct drugs, completely different NDAs, distinct FDA indications grouped together as one drug. Since FDA indication is so far the only way in which drugs have been filtered for the purposes of review, it's critical that this determination be accurate and explained. One category, you have a drug that was removed from the market in 2020. All that is to say that it highlights concerns we have about transparency in the data analysis and the need for a mechanism to point out or correct errors. Again, we request the board establish a process for a manufacturer to request clarification if there are discrepancies in the board's published data and the manufacturer's data. I did hear the recent statement from ED McGrish regarding submission, and we will need to evaluate and consider that consideration. Lastly, I want to raise concerns about the exercise that you did not get to your discussion, but the exercise in weighting criteria, and caution you not to prejudge manufacturer reported information as unimportant. Manufacturers will have insights that bear directly on the board's affordability review, and we urge you not to categorically devalue that information as you perform your affordability reviews. Thank you.
Thank you very much.
Chair Patterson? Terry Lee is not in the meeting.
Okay. So that the presenters right now?
Correct. That concludes the presenters.
All right. And with that, there seems to be a hand up. I don't know how. With that being said, being no further business in front of the board, is there hands keep going up. Melissa, is there something going on in the back end that we need to be aware of, or?
I'm not sure why Terrell Johnson has the hand up. That is related to the public comment. So would you like me to ask?
Please do.
Terrell Johnson, are you related to the public comment for Terry Lee?
Well, Melissa, let's go ahead and public comment. If the individual did not respond and did not sign up for public comment, they're free to do so for next month. Thank you.
I believe that Terry Lee may have had to jump off, and Terrell Johnson is perhaps in place of Terry Lee.
Okay, I have enabled Terrell Johnson to unmute, to change your mic, turn your mute mic on and camera and speak. Terrell Johnson, you do have the control to unmute and speak.
Okay. All right, well, if there
There's
is,
some technical difficulties on their end, Chair Patterson.
okay,
Let me see if Denise Tucker is related to.
they both jumped on at the same time with the hands raised.
And I do want to mention, Chair Patterson, I do have to exit the meeting. The meeting's past our 12 o'clock deadline. Can
Yes, you're.
you if I exit?
Yes.
All right, then I'm going to exit. Thank you, Chair Patterson.
Thank you, Vice Chair Bailey.
Chair Patterson, they both have been enabled, but they.
Hello, Ms. Tucker. Are you here representing someone who was unable to attend? You're muted, so we can't hear you.
I'm unmuted.
There you go. Now we can hear you.
You hear me?
Yes.
This is actually Terry Lee. I don't know what happened. I've been on the call the entire time.
It says Dennis Tucker under your name. That's
So I don't know why I came in under Denise Tucker, but thank you very much for recognizing me. My name is Terry Lee, Mr. Chairman and Chair Patterson, members of the board and staff, and thank you for your patience. My name is Terry Lee and I'm the Vice President of State Government Affairs and Policy at Merck. We appreciate the opportunity to comment and refer you to our more detailed written comments that were submitted in advance of the meeting. I appreciate the prior reference to ensuring accuracy and use of current data. Most urgently, we have significant concerns regarding the accuracy of wholesale acquisition costs, WAC information utilized by the board during the selection process of products. To our knowledge, the board has yet to provide specificity on the methodology used to calculate the WAC information. We believe the current WAC calculations are inconsistent with historical WAC information as reported by commonly used pricing services such as Analysource and Metaspan. More specifically, the board only identifies a single WAC for products that have multiple packages. That was previously referenced. The board has referred to a measure of central tendency. However, this term is not explained and appears to be a compression of multiple data points into a single unit, which in itself does not reflect historical practice. With regards to our product Keytruda, for example, our written comments give examples where the historical WAC information for the product on the working drug list is not consistent with the WAC information for either package size for Keytruda provided by Merck. These inconsistencies risk improperly informing the board's decisions and related future actions and may well result in flawed or inaccurate data about product affordability. Again, we strongly urge the board to provide more transparency on its data sources, the methodologies used in the analysis of the data, and to use a consistent approach when comparing the WAC prices of different products. Overall transparency and input in the process for all interested parties is critical to best support any analysis by the board as it makes decisions. And to further avoid the unintentional effect of faulty data and conclusions, we also request the board establish a secure and confidential process, which we look forward to exploring, by which manufacturers can ask questions or provide input. We also recommend the board prioritize patient access and out-of-pocket cost considerations in the process moving forward, as was recommended in the board's earlier discussion today. As the board continues their work in assessing affordability, we urge the board to consider the clinical value of Keytruda to Oregon cancer patients. Merck has made unprecedented investments in clinical development for Keytruda, resulting in 37 approved indications for patients diagnosed with 16 types of cancers. Merck stands behind the pricing of our products, and Merck has a longstanding history of responsibly pricing our medicines and vaccines to reflect their value and to sustain our investments in R&D and continue to bring our medicines and vaccines to patients. In addition to the concerns expressed here today, we continue to have broader concerns about the potential for the board's work and future actions to adversely impact patient access to medicines and future innovation, which we don't believe is anyone's intent. We thank the board for the opportunity to provide comments today.
Thank you very much. All right. Being that there is no other business in front of this board, and due to that we have lost quorum, the meeting is adjourned, I believe. Ralph, correct?
Yes, correct, Chair Patterson. Thank you.
All right. As always, folks, everyone have a great day and even better tomorrow. Be safe. Cheers.